program for tonight. I think before I start the program, I'm just going to allow us to get to about 200 or 300. I see people coming in very quickly. Let me just make this announcement. This evening is being fully sponsored by Mundi Pharma, who have so graciously funded our event. So thank you very much to Mundi Pharma for the contribution. I think let me start to introduce our speaker. We've got Dr. Bradley Bredekamp with us this evening. Dr. Bradley has a lot of accolades to his name. He qualified as a dentist from the Western Cape in 1994, and then he did his oral medicine and periodontology, which he accomplished he got it in a cum laude in 2003 from the University of Stellenbosch. He's done a lot of publications attached to his name, a lot of other achievements. Dr. Bradley is currently working in a private practice in Durban in South Africa, and I would like to thank Dr. Bradley for giving us his time and giving us this talk this evening. Without any waste of time, please can I just make an announcement? Do not put your questions in the chat box, and do not raise your hand to ask a question. There's a Q&A box at the bottom. Please, if there's any questions, please just place them at the bottom there. Over to you, Dr. Bradley.
Thank you, Ntabi Singh. Let me just share the screen. Can we all see that? Yeah, okay, I think there's a yes. Good evening, everybody, from my side. This is a lecture I've given before, and I took it out of my own interest to find out what is the truth out there, because, you know, in this time of COVID, we get a lot of conflicting information, and some of it is true and some of it's not true, and some of it we just don't know. So I'm not an expert. The topic today is, what does the literature say about oral disinfection and COVID? And I'm hopefully going to give you a summary of the publications that I came across so that you can make up your own mind about what it is that you think it says. So you'll see in my lecture, I haven't put my own notes. I've just taken extracts from the articles and put that up there so you can see I haven't interpreted anything. It's as it is written there. So I'll start off with a disclaimer by saying that this is my interpretation of what I've read. I'm not an expert. I don't proclaim to be an expert on this subject. It's just, I'm like you, I see my patients and I read about this and I wondered, well, what is the truth and what does it say? So I've done a bit of my own investigation, and that's what I'm going to present you with. I don't have any financial interest in any product that I mention here today. So I'm not trying to endorse any product specifically. I'm just trying to speak to us as clinicians so that we know what our patients, you know, need to know. So before I get into the main lecture, there's a few points I just want to make to explain. Now, many of you may know some of these stuff, but I think it's important to explain it basically so everybody's on the same page. And the first thing is that all the tests that we are referring to in the literature are in vitro tests. That means they are laboratory-based tests because we don't have clinical trials published yet with regards to this topic. Those of you in research know it doesn't happen overnight that you can get a research project off the ground, let alone undertake it and then complete it and then publish it. So it takes time, and we've only really had this virus with us for about 5 months that we've really been focused on it. So most of them, all of them are basically in vitro testing. Secondly, there is a big distinction between viral load and bacterial load. So what you must understand is when you have bacteria, bacteria can replicate by themselves. So if I leave, for example, 10 bacterial organisms on a table and I come back an hour later, those 10 bacteria may be 100 bacteria because they multiplied. But a virus doesn't work that same way. So the virus needs a cell of a human or an animal to replicate. So if I drop 10 viral particles on the surface of a table and I come back an hour later, there will be 10 particles. And this is important because, you know, there's lots of studies talking about viral load and how higher viral loads cause more severity and more likelihood of fatalities with this condition. So, for example, if you talk to somebody who's positive and they cough on you and they give you 100 or 10, let's say 10 viral particles. And in a day, it multiplies tenfold. So in a day, you'll have 1,000 particles. If another person gets infected with 1,000 viral particles and the replication rate is the same, then in a day, there'll be 10,000, still 1,000 times. But all of a sudden, the impact on the body is so much greater because there are more viral particles from the offset. And as the days go on, the numbers will exponentially increase the same. But you're dealing with higher numbers in the second scenario. And therefore, if you can reduce the viral load that somebody gets by any means, then you can improve their chances of not getting such a severe disease. The third thing to mention here is when we look at studies, the studies all make sort of assumptions. And the first level of assumption is, does the agent we're talking about here, the disinfectant, does it kill viruses as well? So for example, we look at chlorhexidine, which we'll briefly mention. We know it's a good antiseptic. It's the gold standard in dentistry. We know it destroys a lot of bacterial organisms. We know it may have some viral effects, so therefore we assume it's going to be good against this virus because it's a virus. The next level is where you look at similar viruses. So some of the studies look at like the murine, rat murine virus, because there's some similarities between that virus and the coronavirus. So they're making assumptions on that level. The next level is where you're actually looking at the effect on coronavirus, because now you're dealing with a family that this virus belongs to. So it's a closer relationship. Then some look at the SARS-CoV virus, because that virus shares 80% of the structure of this virus. So therefore, that's even closer. And the final level is where it looks at the SARS-CoV-2 virus, this specific virus for the COVID pandemic. And that's ideally what we want to look at. The last point to make is, what is log10 reduction? So when we look at the virucidal effects or the microbicidal effects of an agent, a lot of it is often described as a log10. How much of a log10 reduction does it cause? So what that means is how many of the viral particles or the organisms does it kill into a power of 10. So a 1 log10 means it kills 90% of the organisms after a period of time. A 2 log10 reduction is 99%. So, you know, we get these adverts where these companies say, oh, we kill 99% of the viruses. That's not actually that good. A 3 log10 is 99.9 and 4 log10 is 99.99, and you get the drift. In the industry, a good microbicidal or virucidal agent will kill to a 4 log10 reduction. So if it's got a 4 log10 reduction or higher, that's good. So you want 99.99% of the organisms to be killed, not 99%. That's actually a 2 log10, which is not that good. All right. So having explained those basics, hopefully you remember them, let's get into the presentation. So I want to start off with this newspaper article. You can see it was in the Philadelphia Inquirer, and it was published in May, middle of May 2020, so about 2.5 months ago, not that long ago. And look at the title, Coronavirus Myth, Mouthwashes Can Reduce the Spread. So why am I starting with this? Because this is what your patients are going to read. They're not going to read a review journal article from Lancet or something like that. They're going to read this newspaper kind of article, and they're going to come to you having assumed that this is fact and well-researched fact. I mean, we know the issues of Facebook and the fake news, but people generally still assume if it's in a newspaper and in print, then it must be 100% accurate. So this lady, Mary McCulloch, says that it's a myth with mouth rinses. And what does she say? So she's basing this article, this journal paper, this newspaper article on a journal publication from Function magazine. This is published by a group mainly from Wales. We'll come back to it later. And where it spoke about using mouth rinses as a pre-procedural rinse against the coronavirus. So she interviews this dean from the University of Pennsylvania, the School of Dental Medicine, Professor Mark Wolf. And what does he say? This is a quote, so I'm assuming it's directly from him. He says the virus doesn't just sit inside the mouth, so that if we swish it, it will be dead. And then he goes on to say a chemical in the mouth, not getting into the nasal cavities and lungs, and if you're coughing, you're reinfecting it. So he's missing the point here. So what is the point? The point is, in most patients, when they get this infection, for the first anywhere from 2 to 11 days, they may be asymptomatic, but infective. And when they're in that period, that incubation period, if you look at what we need to know about COVID, the virus attaches to ACE2 receptors, angiotensin converting enzyme 2 receptors. And what does it say about these receptors? Well, if we look in a study published in 2020 by Zhu et al., it said that the ACE2 receptors expression in the oral cavity mucosa and was heavily enriched in the tongue. So what we're saying is when a patient is asymptomatic and in that incubation period, the viral particle actually does sit in the mouth. The mouth and the nasal passages are where it is. It's not in the lung first, and yet they're infective. And this is not the only publication that says that. Here's that function paper that she's speaking about. And what does it say here? If you look at the highlighted section, it shows about the high viral load with shedding, but the second part shows from GTX gene expression data, you see that the angiotensin converting enzymes, which is the key receptor, is high in salivary gland, higher in the salivary glands than the lungs. Here's a journal from the Korean Medical Society, clinical significance of high SARS-CoV-2 viral load in the saliva. And there are many more that is. It's established that when you're in the early stages, that virus is sitting in the mouth and sitting in the nose. And you are seeing that patient because if the patient was coughing their lungs out, they wouldn't pass your screening test most probably. But the patient that's going to get through your screening test that's positive and asymptomatic is somebody who's got this virus in their mouth and their nasal passages, and that's the area you're going to be working in. Okay, let's look at the next point that is made. Then they go and say that, what about the toxicity? Okay, and they say there's no solid science. Now, this is a 2019 publication that looked at the mouth rinses. And we are talking about mouth rinses that have been around for decades. Over the counter, patients are using it daily to rinse their mouths. You can see, we look at chlorhexidine. And this study showed the only side effect that really reported are taste alterations and staining. Okay, so we're not talking about toxicity here because toxicity is not a big concern to us when with the agents we talk about, because we're not talking about something new. Then she interviews this Thomas Rams, who's from a microbiology testing unit at Temple University. And he says there's no documentation at all. There's no studies, there's no solid data on mouth rinses and COVID. I beg to differ. Look at this article. This was published before. I'm only taking the stuff that's published at this point before or at the time of this article. Okay. This is from American, same country, Philadelphia, same city as the Philadelphia Inquirer. And it speaks about topical preparations to reduce SARS-CoV-2 aerolization in head and neck mucosa. This is another publication which looks at microbial activity. Here's a systematic review. We are taught that systematic reviews and meta-analysis are the higher end of our research, of our publications. This is looking at the efficacy of a pre-procedural mouth rinse in the reduction of microorganisms in aerosol. So this guy's saying there are no studies. I'm not so sure. Okay. She ends up by speaking about the American Dental Association. But before that, sorry, she says, it tastes disgusting, this Professor Wolf also says. Well, you know, I'm sure he has a whiskey or tequila every now and then, and that's not putting him off from having it. And I don't think these things, some of these like betadine, like iorins, some of them are flavored. So that is not really, but it's sensationalism to put you off. And then she ends off with the American Dental Association adding the caveat that there are no clinical studies to support it. And that's true. But if you look at this publication, which we'll come to later on, by top researchers in London, they actually acknowledge that the American Dental Association has recently published interim guidelines for minimizing the risk of COVID-19 infections and transmission, which includes the use of pre-procedural 0.2% povidone-iodine. PVPI is povidone-iodine for those who don't know. So the American Dental Association has actually included in their guidelines. Why would they include it if there's no evidence? So does it make a difference? There's no articles. Well, look at this. These are just a few that I have found at that time that relate to specifically mouth rinses and coronaviruses. I'd say there's more than just a few. But we need to be careful because this is another journalist who's gone and published a paper because an article because his dentist goes and promotes the use of a hydrogen peroxide toothpaste that they're selling and states on the message that it cures, it's a potential cure for COVID. We are not speaking about cures here. We are speaking about something that hopefully can reduce the transmission, the spread of it. And we need to be careful if we're going to put something up like this to our patients, then we need to make sure that we are backed by sound evidence. So let's look into that sound evidence a bit. So if we look at the rinses, I'm just going to touch on 4 of the more common ones. We can look at chlorhexidine, hypochlorous acid, hydrogen peroxide, and povidone-iodine. Okay. So we know chlorhexidine is regarded as the gold standard, as I said, in our industry. Okay, it's a very good antiseptic rinse. It's used extensively. And if we do a PubMed search, so for those again who don't know, PubMed is a free search engine that has all or most of the journal publications in the field of medicine and dentistry on a topic. So if you want to search for something, this is generally the vehicle that you use to go and look it up. So if we look at chlorhexidine and we search that one, we will see over 8,500 publications. Okay, so there's a lot on chlorhexidine, and we know that. But when we look at chlorhexidine and COVID, suddenly we get 4 results. So there's a sparsity. The other interesting thing I want to mention is if you look at PubMed, you'll see here, if you can see my cursor on the right one, it says free PMC articles. Many of these articles on PubMed you have to pay for, and you pay anything from 300 Rand to over 1,000 Rand for just that article, not even the journal. But it's interesting to notice if you go and do search on COVID-related stuff, I'd say 80% of the stuff are free at the moment, which is good because you have access to it to read up on it, and we should make use of that. So we spoke about this article, which was a systematic review, and it says there's moderate evidence that it works against aerosols. And it looked at chlorhexidine, cetylpyridinium chloride, the essential oils, and some herbal products. Now, this article, which is published from a group from Grieswald, Germany, edited by a guy called Gunther Kampf, is one of the most cited and referenced articles when you look at coronaviruses and disinfection. And what they did is they did a review and they did studies to look at how these viruses, these agents disinfect various organisms, okay, and then published it. So what did they say about chlorhexidine? They said 0.02% chlorhexidine digluconate was basically ineffective. And they have a table here. They looked at ethanol, the alcohol, sodium hypochlorite, you can see. So you may say, okay, but that's a low concentration because we use a 0.2% in Corsetal, for example. So maybe 0.02% wasn't a strong enough concentration. Another area that receives a lot of research is when we look at ventilator-associated pneumonia with viral. And they look at these disinfectants in that because it's a big problem. And this study, which looked at it, said that there was limited effect with a 2% chlorhexidine as an antiviral, and chlorhexidine 0.12% and 0.2%, which is 10 times the 0.02%, did not have any protective effect. So chlorhexidine doesn't seem to get a good result. This is a group from a study from a Chinese group where they looked at transmission routes and controls in dental practice. And they actually stipulate, if you look on the right in the pink, that the National Health Commission of the People's Republic of China, bearing in mind they've got the longest experience with the COVID, chlorhexidine is may not be effective in killing 2019 nCoV-2. That 2019 nCoV-2 is the way the World Health Organization says we should refer to it. So chlorhexidine, even though in our hands and our experience is a good antiseptic, and we know it has antiviral properties, the research seems to suggest chlorhexidine is not an effective tool to use against coronaviruses, and therefore there hasn't been much support. So what about hydrogen peroxide? Because a lot of organizations, including our dental association, has recommended the use of hydrogen peroxide. So when you do a search for hydrogen peroxide and COVID, the interesting thing is that most of the publications that look at it as an effective agent looks at hydrogen peroxide vapor, okay? And most of it is used in the disinfection of these N95 masks because we have a shortage, or we had a shortage of these masks, and so people had to reuse them and they were disinfecting them. But if you look at the concentrations of these vapors, 35% is an average, weight by weight. The lowest I could find was 7.8%. That is quite higher than our 1% and 3% that we are using and advocating. So let's go back to Kempf's publication, which looked at the hydrogen peroxide. The other important thing to note with the vapor is it takes long. And it's fine if you're sterilizing a mask because you'll use another mask and you'll come back a day later. But if you're having a patient there, look at the time frame in the last column for hydrogen peroxide. Firstly, they don't state in the second column what concentration. They haven't even got agreement on concentration, but it's 2 to 3 hours. And look at the other agents, the ethanol, all talking about 1 minute. So it's very slow, okay? This was an interesting publication I came across. So this is in pre-proof, so it's been accepted for publication, but they're obviously doing the typesetting and all the copywriting and all that. And this is the medical hypothesis. This is a group from Italy. And their hypothesis was to look at hydrogen peroxide and viral infections, a literature review with research hypothesis. So they're developing a research hypothesis because we know hydrogen peroxide is involved in the immune system, in natural immunity. So they're saying, well, therefore it must be effective at COVID. And they're testing that hypothesis. And I'll just show you this page. So there are 3 points I want to bring your attention to. The first part is if you read that first green highlighted section, they say a hydrogen peroxide solution of a concentration of as little as 0.5% efficiency inactivates coronaviruses. 0.5% hydrogen peroxide solution. Okay, I'll come back to that. Then they go and say in their conclusions, there are no randomized controlled trials or clinical observation studies that concerning the curative or preventative effect of hydrogen peroxide against viral infections. But they finish off by giving us a recommendation of how we should use a nasal spray and a rinse. So it kind of makes me wonder, what's the point? You've done a systematic review. They looked at 26 publications, they said. They show there's no curative or preventative that they can see, but they're telling you how you should use it and say, well, we should investigate more. That's the kind of research we're sometimes getting here, people. So just because in print, we need to be careful. So if we look at hydrogen peroxide mouth rinse and COVID, we did a Medline search again, no results. And coronaviruses, no results. So look at Cam's study again, okay? And if you look at what he says here in the blue section, he says hydrogen peroxide was effective with a concentration of 0.5% and an incubation time of 1 minute. So now we're looking more promising because it's 1 minute, not 2 to 3 hours. And they're saying hydrogen peroxide is effective in a concentration of 0.5%. What does that mean? So this publication, if you look at the bottom, you may not be able to see, this was published in 2006 by a Canadian group. Okay, Navid Omid-Baksh and Syed Sattar. And they looked at the broad spectrum microbicidal activity of a new generation of accelerated hydrogen peroxide based environment. So what is accelerated hydrogen peroxide? So if you can see the underlined area, they look at the human coronaviruses. So they're looking at the family of coronaviruses. And if you look at the last line, it's greater than a 4 log 10 reduction. That's good. We said that's great. That's 99.99%. But if you read the article more closely and you look at this underlined section, firstly, the first thing you notice is there's a patent number, a new generation of patented. And they speak of a 0.5% accelerated hydrogen peroxide. So is accelerated hydrogen peroxide the same as hydrogen peroxide? Because Camp and them just stated it as hydrogen peroxide. Okay, let's look at them again. Here's his article. Here's the table on the right. So if we look on the right, he speaks of a hydrogen peroxide, not accelerated, 0.5% for SARS. And look at the reference. The reference they have there is number 34. If you look, I hope you can see it on the right-hand side column, that blue. So let's go to his references. And I have to put it like this because I wanted to show you it's from Kempf. You can see the top of that image that just came. It's Kempf et al., same journal. Look at number 34. Omid-Baksh, Sattar. It's that same article I just showed you about. But that article spoke of accelerated hydrogen peroxide. Didn't speak of hydrogen peroxide. So if we read up on hydrogen peroxide, we find hydrogen peroxide is actually an unstable substance, okay? That you only achieve low levels of activity and slow-acting antimicrobial. What does it say on the right? The 3% hydrogen peroxide in this form is known to be very unstable with a relatively short shelf life. And then accelerated hydrogen peroxide is active results on there. If we search for it with COVID, not so much, in fact, nothing. and coronaviruses the same. So it seems that the only hydrogen peroxide that seems to be effective is the accelerated hydrogen peroxide. That's one study. There's no other studies to show that that's effective. Okay, so let's look at hypochlorous acid. What is hypochlorous acid? So hypochlorous acid is basically called electrolyzed water. So what you do is, there are 3 different ways you can get it, but the most common way is you take salt water, you add an electric current through it, and it creates, depending on the pH, hypochlorous acid, sodium hypochlorite, and so forth. So this belongs to the chlorine family. But hypochlorous acid is the most potent of all these agents, even chlorine dioxide. It's actually on the World Health Organization's list of essential medicines that they've got. That's how important it is. The best thing about this is it is very safe. You can actually drink this. And it is said to be between 80 and 120 times more potent than sodium hypochlorite, which is your bleach, your Jik and your Milton and so forth. So how do you achieve this? So when you have the pH of the solution between 4 and 6, ideally about 5.5 to 6, then virtually all of your solution is made of hypochlorous acid. When you go above 7 and it becomes more alkaline, then you get your hypochlorite, like your sodium hypochlorite. So let's look at this. If we look, this is a test result from the Korean Ministry of Food and Agriculture. They used it on H1N1. They showed how effective hypochlorous acid was in inactivating the virus within 15 seconds. Here on the right, read this section. It says, hypochlorous acid water shows high bactericidal and inactivating activities against various pathogens, bacteria, and viruses. And their activity is higher than 70% rubbing alcohol. So it's as effective, if not higher than rubbing alcohol, but it's safe. It's not corrosive, doesn't stain, it's safe. You can even drink it, so there's no issue of accidentally ingesting it. In fact, the FDA approves it for eyes and in the mouth and everywhere. So if we look at studies looking at it, this was a study that looked at the avian influenza, so it's the family of coronaviruses, but not as specific as the SARS viruses. They actually looked and they did various concentrations, and they found that 200 parts per million solution inactivated the virus within 10 minutes, they said, while 50 and 100 parts per million could not inactivate it. So they're saying that you should at least use the 200 parts per million. This study on the right looked at a similar virus like the murine hepatitis virus I said to you. But look at this interesting fact. They didn't look at hypochlorous acid. They looked at sodium hypochlorite and showed it was effective. Now, bearing in mind hypochlorous acid, so again, they're mixing the two up. They're not being specific here, and they're publishing these things. And hypochlorous acid is supposed to be 80 to 120 times more effective than sodium hypochlorite. This is a very interesting article because I don't know how many of you know this, but you know the immune system, and you know our cells and our immune cells in our body, our phagocytes go and they eat up these organisms. Do you know how they do it? They do it by producing hypochlorous acid. Our own body uses hypochlorous acid to kill organisms. That's what our body does. But look at what they say here. They said both hydrogen peroxide, remember I said to you that other study said it's used in the immune system, and it says both hydrogen peroxide and hypochlorous acid have antimicrobial activity, but hypochlorous acid is much more potent. So if it's safer to drink or consume, and it's so much more potent, why, and it's not corrosive, why are we not using this more? Okay. This is an article by a group of maxillofacial surgeons. You can see in the Journal of Oral Maxillofacial Surgery, published now 2020. And they looked, and what they said is firstly, that the US Environmental Protection Agency has recommended numerous disinfectant agents against COVID-19, including hypochlorous acid. So hypochlorous acid is recommended as a disinfectant. So when you want to do your surface disinfection, instead of using alcohol or one of these other corrosive agents, why not use hypochlorous acid? It's cheap, it's safe, it doesn't cause issues. Then they go on to show the concentration for virucidal action. And it showed that it destroys many viruses, including coronaviruses, in less than a minute. So now we're getting to a time that's a bit better for our patient, not hours, but minutes. Interestingly, that says you have to have pH levels between 3 and 6. So important when you're looking at your, if you're going to use hypochlorous acid, there are various guys that supply it. We've got a couple of guys in Durban that supply it. Make sure your concentration is above 200 parts per million. We use 350 or 500 parts per million, and make sure your pH is between 5 and 6 ideally. So you don't want a high pH. This is the same thing that the others have said. There's commonality in the message, so there must be some truism in it. Okay. What do they say here? They say here at the bottom on the left, you see that hypochlorous acid specifically used for hand sanitizers and is effective at 100 to 200 parts per million strength. Okay. And there's a study that found you got between a 3 to 5 log 10 reduction when using this against these viruses. And it's used in fogging machines as well. I'm not here to talk about that, but if you want to use your fogging machine, then you can use hypochlorous acid. Okay. And the half-life is relatively short. I know there are dental companies that even sell you machines that make the hypochlorous acid. Okay. And it's effective for up to 2 weeks. So you can choose whether you want to make it or whether you want to buy it ready-made. But hypochlorous acid shows some promise. Then let's look at povidone-iodine, the last one. So povidone-iodine has been used for over 50, actually 60 years. Povidone-iodine. Iodine has been used for centuries. Okay. And this study was a study done by a group of Japanese researchers where they looked at povidone-iodine, and they found that when you use it prophylactically and gargled with it, it reduced pulmonary infection episodes by almost 60%. Let's come back to Kampf's publication. What do they say about povidone-iodine? They mention a whole list of alcohols there, you can see, which we've been taught at the beginning was that 70% alcohol was the best to use, but they showed povidone-iodine from 0.23 to 7.5% readily inactivated coronavirus infectivity by approximately 4 log 10 or more. That's good. We said 4 log 10 is good. So that shows promise. Let's look at the table. So if you look at the table and you look at 70% alcohol, like I said, we've been told that's good to use. And you look at SARS-CoV, that's that line, if you follow it across, you can see after 30 seconds, it was greater than 3.3 log 10 reduction. So that's 99.9%. If we compare that to povidone-iodine at the bottom, you can see a 0.23% SARS-CoV-2 after 15 seconds, half the time, had a greater than 4.4 log 10 reduction. So in half the time, it actually killed SARS-CoV-2, the family of coronaviruses, more effectively in half the time than 70% alcohol. That's promising. So if we read this article, where they look at povidone-iodine gargle or mouthwash, because notice previously they said 0.23. That's a very specific concentration, not 0.2, 0.23. And where does that come? This is a study published, and this was published in 2018, I'm right. Okay, you can see over there, if you can see. So this is before the coronavirus pandemic, by a group in Germany, led by a lady called Marianne Eggers. And what they did is they tested povidone-iodine at different concentrations, from a high of 7% to a low of 0.23%. And what they found, if you read on the right, was that at a concentration even of 0.23% after 15 seconds, there was a 99.99% reduction. Okay, so that's a 4 log 10 reduction of a concentration as low as 0.23%. Now, being skeptical here, I have to admit, this lady works for Mundi Pharma, who supply betadine, which is a povidone-iodine. So you may say there's bias there. Maybe there is. So let's read further on. This is another study by a Japanese group looking at the inactivation of SARS coronaviruses with povidone-iodine. Okay. And what did they find? They found within 2 minutes, it completely inactivated the virus, completely. Whereas the treatment of 70% alcohol, ethanol, also reduced the virus infection. So it didn't completely reduce it, it reduced it. That sounds good for povidone-iodine. Let's go back to that function publication, that article that Philadelphia newspaper reported on, that they did a review on. What did they say? They actually said that, remember I said to you that in the Japanese study, they found how effective it was for reducing respiratory infections. That in Japan for years now, they have recommended a daily gargling with 0.23% povidone-iodine. Okay. You can see the Health Ministry, Labour and Welfare support the daily gargling. And they found not only well, SARS, the coronavirus, but flu, influenza, has drastically reduced by daily rinsing and gargling. So they recommend to their population to use this as a regular gargle. This article, which looked at the prevention of infection disruption of pathogens in the Journal of Arthroplasty, actually states that povidone-iodine, dilute povidone-iodine, if you look at the last half of that pink or purple highlighted section, was tested against SARS, MERS, the family, and Ebola, and found to have absolute efficacy, even Ebola. Okay. So here's this function article again by this Welsh group. Okay. And they also say that because it's so potent, it's actually also made it onto the World Health list, the World Health Organization's list of essential medicines. So this is an article I've come across more recently now after the publication. And I like this because what they do is they compare povidone-iodine virucidal activity, okay, in a disease. And they showed at all the different concentrations as an antiseptic, as a throat spray, as a skin cleanser. Look at that. All of them have a greater than 4 log 10 reduction. So greater than 99.99%. Okay. And the other important thing in this publication, with a lot of these agents, when you have organic material, it reduces the efficacy of the agent. But they found with povidone-iodine, there was actually no difference whether it was a clean surface or a dirty surface on whether this actually killed off the organisms. And so they said that the Australian Dental Association and the United Centers for Disease Control and Prevention have recommended the pre-procedural use of povidone-iodine. What about this study? This study is a comparison of SARS-CoV-2. So now it's in the American College of Prosthodontists. This is looking at the specific organism, not the family, not just the virus, but SARS-CoV-2 virus. And they're comparing hydrogen peroxide with povidone-iodine as an oral antiseptic rinse. This is what we want to know. Okay, BIDRA, this, and they're from America. Look at the last row. Look at the povidone-iodine. They tried a 0.5%, 1.25%, and 1.5% at 15 seconds. It had a 4.3 log 10 reduction. Look at ethanol, alcohol, which was the control. That also had a 4.3 log 10 reduction. Look at hydrogen peroxide, 3 and 6%, which in concentration comes to 1.5 and 3. That's 1.3 and a 1 log 10 reduction. That's not even 99%, that's 90%. Okay, big difference in that. And this is comparing the actual organism, and this is hot off the presses. If you look, this is accepted for publication now, the 28th of June, 2020. So that's a month, just over a month ago. So their conclusion is that you have to use a povidone-iodine, and hydrogen peroxide at the different concentrations is not effective. So this is the publication I mentioned right at the beginning, and this is not yet printed. It's done by a group in England, and one of the co-authors is Professor Stephen Shalacombe. Those in the oral meds circles know he's world-renowned in oral medicine. And they looked at the use of povidone-iodine as a rinse. And what they did is they recommended, they did all the research in terms of the publications and reviewed it and did their own, and they recommended 2 steps. The first step is the use of a 0.5% solution of povidone-iodine as a nasal spray. Okay, they tell you to close the one nostril, squirt in the other, and breathe it in. Now, we don't have a nasal spray. I'll be honest, what I've been doing is I've been using an earbud, having the patient soak it in, wipe it in, and sniff it. But that's just, there's no scientific evidence. It's just, we don't have a nasal spray. You can make up your own, but that's a bit of a lot of work. And then step 2 is where you take 9 milliliters of the 0.5%. And why they say 0.5%? Because they said 0.23 is the minimum concentration. So let's double that, just in case it gets absorbed and there are other organic compounds. But as we know from the studies I mentioned before, that doesn't seem to affect the effect of povidone-iodine. But nonetheless, they said a 0.5% solution. Bearing in mind, betadine is a 1% solution. So that's even double 0.5. And you gargle for 30 seconds, and then you rinse for 30 seconds, and then gargle or hold it at the back of your throat for 30 seconds. And they recommend it not only for your patients, but they recommend it for us as oral healthcare workers as well, that we do it 2 to 3 times a day. Because even if we get a virus in us, we will reduce the risk, the viral load. So that will reduce the risk, the infection and the disease that we suffer from. They've also done the calculations in terms of the diffusion of the mucus, the secretion of the mucus and saliva from the oral cavity and so forth. And they calculate by their conservative estimation, if you use that protocol, it should give you at least 20 minutes of protection. Okay, so you're going to say, well, geez, I've got to be quick with my root canal or my crown prep. No, because what you do is you use it for as the protocol, it gives you the 20 minutes. The 20 minutes is enough time for you to put a rubber dam on, and the rubber dam then protects you further from that. They've also looked at the issue of toxicity. People talk about, yeah, but it's toxic. Toxicity is very rare with povidone-iodine, very rare. And most of the toxic reports, that even the rare ones, because they're rare, have looked at the 10%, which is what we do on the skin when they're doing surgery in theater. They don't look at a 1% or 0.5% solution. There aren't reports on those reactions. So it is very safe. Even patients with thyroid, they've done the calculation. There's no significant changes when patients are using a 0.5% povidone-iodine as a rinse. So you may hear about this. This is molecular iodine called IoRinse from a company in America. I think it's a Canadian company based in Tampa. And this came out about 3 years ago. So what they claim is that when you look at iodine, like in betadine, for example, they say that betadine has about 31,600 parts per million of iodine. But that iodine is made up of various forms of iodine, like iodide, iodate, triiodine, and so forth. And only 1 to 3,000 parts per million of it is actually molecular iodine. And it's the molecular iodine that is the active agent in its antimicrobial effect. So what they've done is they've managed to sort of concentrate it. So they have a much lower, they've only got like 1,000 or less than 1,000 parts per million of iodine. And of that, 600 parts per million is molecular iodine. So they said they've concentrated it, which means you've got less toxic risks, and it's got a better taste, it's flavored, and so forth. The interesting thing is when they look at the laboratories, that they've got a laboratory that's looked at it, they don't compare their IoRinse to povidone-iodine. They compare it to chlorhexidine. But I want to know if you're better than iodine, because we know how well iodine works. I've just given you lots of studies, and there are more. Compare it to that. I've been sent an email to say there is a study being done in America that should be coming out in the next 3 weeks, but they compare it to chlorhexidine and a 0.2% povidone-iodine, which is not fair, because if the literature shows you at least 0.23%, then you should use the lowest concentration that is shown to be effective to make a comparison. But the other interesting thing is, and I'm not saying that this thing isn't right, this IoRinse isn't a good product. I'm just saying that this publication, which is the only thing I can find, there's no peer-reviewed journals at the moment, is written by Herb Moskowitz, who is the owner and founder of the company, and a lady called Janice Goodman, who says that she's got financial interest in the company. So maybe we have to wait till we get independent review of this product before. But I have used it, and it does taste nice. That's what much I will give it. Okay, so in conclusion, there, in my opinion, is reasonable evidence for a pre-procedural mouth rinse to be used. It's been used for a long time. They're inexpensive and they're readily available. Not all of us can afford these high evacuation vacuuming suctions or these air filters that purify the air. So if you can't do that, then use your PPEs and use your rubber dams and use your pre-procedural mouth rinse. And if you do that, as Shalacombe then said, as an adjunct to currently recommended PPE solutions, they recommend the use of this pre-procedural mouth rinse, and maybe, just maybe, we can contribute in some small way to reducing the spread of this disease amongst our population. And I say thank you to you for listening. How have I done for time?
Very much, Dr. Bradley. That was very informative. And I think you gave a lot of information that people have been longing to receive. Before we get to the questions, let me acknowledge Dr. Amina Peer, who is from Mundi Pharma, she's also going to assist with some of the questions if there are any questions related particularly to their products. So thank you very much, Dr. Pierre.
Thank you.
I'll go to the questions, Dr. Bradley. The first question from an anonymous attendee: will it be beneficial for you and your staff to rinse with 1% hydrogen peroxide in between patients? The thought behind this is if you inhaled or ingested a virus particle, that you may eliminate it before it multiplies in your oropharyngeal area.
Sorry, I just got disconnected there. So I hope this question was asked at the start of my lecture, because I think I've answered that through the lecture. So it is beneficial to use a pre-procedural rinse, but according to the literature, hydrogen peroxide is not the rinse you should be using. You should be using a povidone-iodine. Now, the question I often get asked is, what happens if people are allergic to iodine? And like I said, it's rare, but if you have any doubt, I would then just use a hypochlorous acid mouth rinse. But like I said, but my first choice would be povidone-iodine rinse, because that's well documented. And if somebody is worried and you're worried about allergy, then I would use a hypochlorous acid rinse.
As I was skimming through the questions, Doc, we did get a lot of questions asking about allergies. So I think maybe you may have covered those ones. What type of nasal spray do we use? That's the next question.
Well, that's what I said. They give it in there into a 0.28 to 0.3%, 0.38 volume in a pump that disperses. But you've got to make your own one at the moment. I've been told by Dr. Pierre that a nasal spray is coming from Mundi Pharma with regards to betadine. I've also been in that email that I got regarding iorins, because I think Milner supplies it. They also said that they're bringing out the nasal spray for the iorins as well, which is molecular iodine. So it's coming, but at the moment we don't have it available. So that's why I said what I'm doing at the moment is just using a cotton bud, earbud, soaking it in, wiping in, and having them inhale. And I let the patient do it, because it's very uncomfortable for a patient if you go in and put stuff up their nose. But if they do it themselves, they're more comfortable doing that. That's what I'm doing at the moment.
Yeah, if you've done a COVID test, you'll know that putting stuff up your nose is quite uncomfortable.
I've had two, don't worry, I know it.
I've also done it twice, Dr. Bradley. So how do you mix hydrogen peroxide to a 1% solution?
Well, that's got to do with your formulations. That's the pharmaceutical company. They mix it in a carrier solution and they work up the concentrations. I mean, that's pharmaceuticals. I don't know if Amina wants to add anything, because with that regard, how do you make up your concentrations?
Yeah.
With regards to hydrogen peroxide, I don't have any comments. If the doctors want the literature or the articles of the global experts in terms of how they have been, preparing their nasal sprays using the Povidone-iodine solutions, I can send those to them. If they can just, send their email addresses to SADA, and then I can send them the articles, and then they can read through it and prepare it accordingly. It will be an off-label indication because we don't have a nasal spray in South Africa.
I think what they're asking is just how do you make up the various concentrations? So how do you come up with a 1%, let's say betadine povidone-iodine solution, as opposed to a 0.5%?
Okay, so if you look at what is available in South Africa, we have the mouthwash and gargle, which is 1%. So that is what is available in South Africa, but it's available in terms of the as gargle. In terms of diluting it, you would dilute it, to get it to 0.5% would be 50% sterile water with 50% of the 1% solution. So that would be the easiest to bring it down to 0.5%. And then of course, if you wanted to 0.25, then you would reduce it accordingly. Does that answer the question?
I think it does. Thank you, Dr. Pierre. Dr. Bradley, Sean Napier wants to know, or is firstly starting by thanking you for a very interesting and informative lecture. Since we know that the ACE2 receptors are where COVID-19 attaches and are present in an asymptomatic patient who is in the last hour before symptoms appear. This is the most dangerous patient, Dr. Napier says. Would it be correct to assume that there should be no differentiation between AGP and AGE with regards to how dental professionals prepare for any patients, PPE, pre-procedural mouthwash, etc.?
Well, Sean, I'll answer your question by saying that I think we see the numbers that are happening there in South Africa at the moment. I mean, the escalation in numbers are high. We also know, I know about 2 weeks ago, the Center for Disease Control released a statement that they predict as many as 40% of people are completely asymptomatic. You know, and that's why, you know, we're measuring with these thermometers, and firstly, that's measuring our skin surface temperature. It's so inaccurate. It's not the body's core temperature. And then you add to that 40% may be asymptomatic and not at temperatures, and yet you think if the patient's got a temperature that's 36, then they're safe. So the point I make is that we must assume that every single patient in your practice that you see is COVID positive. That is where we need to go. We can't assume and be lax. That is why every patient, you should wear your full PPEs. As a dentist, you should use a rubber dam and you should use a pre-procedural mouth rinse. Because if you do, or when you do get that one patient that you don't know and they're COVID positive and you've taken all these precautions, and yes, if you want to do the fogging and if you want to do your high evacuation system, all of that, that's great if you have the means. But I'm looking at cost-effective means for a dentist out there who can't afford these things. And it's not expensive to get this mouth rinse. It's not expensive. You can get PPEs at relatively low cost. And remember, that's a cost the patient has to pay and should be paying. And SARDA should be sitting with the medical aids and making sure that they cover us well enough for that. And we take those measures and we use a rubber dam. Then you protect yourself well enough that you won't catch the virus. And I hope that answers it, Sean.
Okay, thank you, Dr. Bradley. Mike Windish is giving you.
Thanks, Mike.
Yeah.
He's representing Durban. He's one of our Durban dentists.
And then Anonymous wants to know, nasal sprays, what type and where do you buy this from? I think the
Again,
difference
like I said,
between,
they're not yet available, guys. We have to wait. I think you should all bombard Dr. Pierre with when are we getting this so that she can get everything fast-tracked here for us. The
Dr.
question, though,
Pierre,
interesting question for me on the nasal spray is, what happens when we do get it? Because I was telling Dr. Pierre, ideally, I would have loved them to develop a nasal spray bottle with interchangeable disposable tips, because you can't use a nasal spray on a patient and then use it on another patient. So you are then going to, each patient's going to have to get their own nasal spray. So do you get the patient to buy it beforehand and bring it with them? Do you sell it to the patient as your practice? Because you're going to go through a lot of nasal spray if every patient has to get it. That's the interesting question to ask. How do we make it cost effective for us?
Maybe they can, maybe since Dr. Pierre is here, maybe they can put disposable nozzles at the top and make them very reasonable.
I'm putting more pressure on her here now since we got a bigger forum here.
Yeah, so the information has been shared, or the request has been shared with our R&D division, and so they are in process of going through the stages of the the research behind the nasal spray, and so those things will be taken into consideration when we are ready to go to market with it and in production, I would assume. Yeah.
Thanks, Dr. Pierre. Dr. Mohammed Mayat is giving you another shout out, Dr. Bradley.
Thank you, Dr. Mayat.
And then Dr. Erasmus wants to know, where do we get hypochlorous acid? And he wants a specific company name.
I don't want to there are several companies that you can get them from. There's not just one company, and I'm not here, like I said, to promote a particular company. So what I'd suggest to Dr. Erasmus is check out there in your area. I don't know where you live. If there's a company, you can Google it. If you can't come right, feel free to contact me privately and I'll tell you where we're getting it from. There's a Joburg-based company, there's some Durban-based companies. There are quite a few companies that you can get it for. That's why I say, like I said, there's a dental company that actually sells the machine that makes it. I think it's about 5,000 Rand for the machine. So you can look at that also. But when you're looking at these products, just make sure they've got the right parts per million, at least over 200, and make sure they've got the right pH. Ask them that it must be between 5 and 6 pH, ideally between 5 and 6, but not higher than 6.5.
Okay, thank you, Dr. Bradley. Dr. Cavalieratos wants to know, has hypochlorous acid been used in endodontics? Question, if it's stronger and safer, is that not a good agent to use?
Good question, Spiros. So one of the dentists here, Nadia van Beek, she's friends with the head involved in research at one of the universities. And she said they looked into this because they asked that same question. What they found, though, was the hypochlorous acid doesn't disintegrate the tissue well enough, which is what you also want. So therefore, they said for basic endos, and I'm going on hearsay, this is what she told me, because I don't deal with endos. She said that they find for normal endos, it's maybe not the best to use. They'll stick to the sodium hypochlorite, but for pulpotomies and when you're dealing with kids, and you want to flush it out, that may be a good indication because you're not going to get reactions to it. But those are her words. That's all I can say on that matter.
Okay, thank you, Doc. Dr. Kinsley wants to know, would it be possible to use hypochlorous acid in our water supply for our handpieces?
Yes, Dr. Kingsley. In fact, they use it routinely in sewage purification systems. They use hypochlorous acid. Countries use that in there. So yes, so it should be more forgiving on your systems if you use it, because like I said, it's not corrosive. It's a very weak acid.
So then that answers our next question.
Yes,
Bradley.
yes, Mac. I've answered that question.
It's a no. Okay.
Just to give you an idea with hypochlorous acid, it is actually used on cruise ships to spray the food. Remember, they got all these big buffets out there, and people are eating off them, and they don't. I mean, you can imagine the disaster it'd be if you get food poisoning on these cruise ships with thousands of people. That's what they do routinely. They spray it with hypochlorous acid because you can't. It doesn't have a taste. Well, it does. If you get to the higher concentration, like 500 parts per million, it can have sort of a slight bleachy taste. If you're dealing it with like 200 parts per million, it's very mild. So you don't want to affect the taste. So that's what they're using it at.
And then we have got another question on allergy, which you have addressed as well. What is the concentration of Povidone-iodine recommended as pre-procedural mouthwash?
So according to the Shalocombe study, it's 0.5% is what they recommend. The lowest concentration is 0.23%. But they would say, and remember the 0.2, remember the other thing is also, the 0.23% killed, if you remember, killed the virus within 15 seconds. So if you're giving it 30 seconds, because they actually recommend a 30 seconds gargle and a 30 seconds rinse, swish around. That's a minute. It's a long time. I sit there and I time the patients. Most patients don't do it for that long. So they'll usually do it for about 30 to 40 seconds. So if this thing kills it in 15 seconds, you're well covered in that regard as well. And then if you're adding double, like if you're using like a betadine, and I'm not just saying this to punt Mindy Farmer, but if you're using a double concentration, like a 1% betadine at a 30 seconds, then it should generally kill the bacteria quite effectively.
I've got another very interesting question here, Dr. Bradley. What advice or comments could you give when patients think these mouthwashes are killing?
That's a good question. Tell them they've got enough good bacteria that they'll still survive. But at the moment, we got to protect them against coronavirus. That's what we do.
Okay, and I think the next question is also product related. From who do you buy your Povidone-iodine?
On that question, I just want to make one comment. I went into the pharmacy last week and I was looking for some betadine and they were out of stock. And they had a Povidone-iodine rinse by another pharmaceutical company. And I looked at it and it was a 0.1% Povidone-iodine. Now remember, the research shows 0.23% is the lowest concentration. So be careful, don't just go buy Povidone-iodine. I mean, I haven't looked at all the Povidone-iodine rinses out there in the market. So just check the label, because I didn't even know there was a 0.1%. And it's a brown, I mean, really a typical, Povidone-iodine solution, because I tasted it as well. So be careful, make sure it's higher than 0.23% that you're buying, because you can get lower concentrations in the pharmacies, the supermarkets.
Thank you very much, Doc. Here's a question that wants to know, which one would you choose between hypochlorous acid and Povidone-iodine?
At the moment, I would choose the Povidone-iodine purely because there is more supportive research on its viral killing abilities than hypochlorous acid. There is on hypochlorous, but there's much more on Povidone-iodine, which is why I said that is my first line. And only if I suspect allergies or I'm concerned about it, then I would use hypochlorous acid as the second option.
Dr. Bredekamp, there are many questions that I have allowed you to skip, but this one, I want you to answer it because it's got 4 question marks. Brad, why are you not an advisor to the minister?
I don't know. They haven't come to me yet. But I'm not sure I want to be honest, even if they do. I'm happy where I am. Thank you.
Yeah. Then you have a couple of people giving you praises and beautiful comments there. And then we've got others for allergies.
There's a question from Mike Sparks about hypochlorous acid. I don't know what you're asking about hypochlorous acid, Mike. I thought we had covered hypochlorous. There's a specific question about
hypochlorous. Yeah, Mike just says, what about it? Yeah, and a question mark.
Maybe it came after the hypochlorous acid section.
Yeah. Okay, I think a lot of them are comments.
If I have just made it clearer to the members, if I've just made it clearer to the dentists out there as to what is available and what does the literature say, then I'm very satisfied with the efforts I've had to put in to get this information.
Okay. So here's a question, Dr. Bradley. Which companies besides Milner's is stocking the Povidone-iodine rinse? Because Milner's has out of stock.
Yeah, so just to clarify, Milner's stocks the IO rinse. That's the one they stock, which is the molecular iodine, the new product, the new patented product. They don't stock Povidone-iodine rinses. So Povidone-iodine rinses are the betadines, and those you get you can get at the pharmacies. I know they're out of stock. The wholesalers have them. I'm sure they're going to charge a markup on them. So hopefully they don't see this presentation. But yeah, you can get them at most pharmaceutical. The other thing that's also happened here in Durban, we've also had some pharmacies make up the solution, because it's not a very difficult solution to make. The only thing is it doesn't taste very nice when you make it up yourself. It's not terrible, but it's not that nice. But you can approach a pharmacist to make it up for you as a 0.5% solution. Sorry, Amina, but you're out of stock in any case, so.
I just want to make a comment on that. Yes, the betadine caution gargle has been selling very well, and stock has become an issue. But there has been a consignment that has come in this last Friday, and it's out to the wholesalers and probably be in the shops or the pharmacies this week. The places they can find it would be Dis-Chem and Clicks, or your pharmacies. And the wholesalers the pharmaceutical wholesalers also keep the product. So if anybody is looking for it, they can start placing their orders, because it is the stock that came in this last Friday. Yeah.
So just to answer Mike Sparks, is it adequate? Yes, Mike, if you're using a concentration of higher than 200 parts per million and a pH of between at least 4 and 6, then it's been shown to be adequate against killing the coronaviruses, yes.
Okay. And I think, Dr. Pierre, this is another question to you. Please explain how to make 0.23% iodine solution, or you mentioned something about 0.5. Or
that's, I was going to say, that's the guy who made sure he just got 50% for his exam. He didn't want anything above 50% is a waste. He wants 0.23% iodine.
Okay, so I think I've already answered this question, but if you look at the mouthwash and gargle, it is 1%. If you used, 50% sterile water with 50% the mouthwash and gargle, that would give you a 0.5%. So a 0.23% would be probably, I would say 1 part is to 3 parts sterile water, because it's half of the 0.5%. Does that make, so 1 part Povidone-iodine to 3 parts sterile water of the mouthwash and gargle specifically, which is 1%, yeah.
I think it does answer the question. Can hydrogen peroxide 3% solution be used in a nebulizer to inhale, since we don't have any iodine nasal sprays yet?
I like the idea of the nebulizer, Ravina. The thing is, look, there is no research that I have come across that shows hydrogen peroxide in a 3% solution works against, I'm talking about specifically about coronaviruses. So I would, if I'm going to try it in a nebulizer, I would actually most probably try a hypochlorous acid as a nebulizer. And that's just me rationalizing it. But hydrogen peroxide doesn't help to use hydrogen peroxide because it's not shown to be effective against the virus.
Okay, thank you. Anonymous says, I think you mentioned hypochlorous acid has a short half-life, but they sell it in 5 liters and 25-liter containers. Does this mean they become inert in a few days?
So it's unstable, but the half-life is 2 weeks. 2 weeks it's stable for. So it becomes a bit more unstable. And so my advice to you is work out how much you're using. Like I use it for my surface disinfection in the practice. So I know how much I go through a week. And so I don't buy more than a 2-week supply because it's readily available. I've never had so far an issue with getting stock. Maybe I will now if you guys all start using hypochlorous acid, but anyway. So far, so don't buy 6 months because it's not a very expensive product to get. And like I said, if you're finding that you're worried about how your usage is, then maybe buy the machine that makes it. Some guys have done the calculation and they've worked out that, I know one guy's worked out that after a year, the way he's using it, he will actually have made back the money that he would have bought if he bought it from an agent. So he decides to buy the machine. That's your choice.
And here's a question. Would the pre-procedural rinse be beneficial to other healthcare workers like GPs and physiotherapists, etc.?
Yes. Think of it this way. Just imagine if this thing works. Remember, these are all in vitro studies, right? So they're not clinical-based human studies because you're going to struggle with ethics and all that to get it through. But we've shown that it kills the virus quite effectively. Now imagine if all of us have our patients rinsing with this, don't you think it would make a possible impact on the spread of this disease amongst people? Because if you look at your contact tracing, and even if it makes a 10% difference, you know what an impact that makes on the country, on the economy, on people not being sick. And we can go forward and push that as dentists. Let the dental fraternity start, and hopefully our medical colleagues, the ENTs should use. In fact, I've got some ENTs who listened to this lecture before, and they are implementing it in their regular practice. Because we as healthcare workers, this is how we can make a difference. And there's no harm to the patient. It's extra protection, so it's just another one of those extra tools we can use. But if it's effective enough and we can get it widespread enough, we can actually make an imprint, an indent on the spread of this virus in our population. It's possible.
Thank you, Doc. You're right. Have you heard of hydrogen silver? If so, what are your views on it?
I've heard of it, but I haven't researched it. So I can only comment on the stuff that I've done, quite extensive reading on. So I don't want to make comments on that. Sorry.
Okay. Dr. Bradley, here's a question that is asking, is 0.2% chlorhexidine not effective in comparison with Povidone-iodine?
See, I'm just saying with some of these questions, I can see who is not listening to my lecture. So no, chlorhexidine has not been shown to be effective. A 2%, a 0.12%, a 0.2%, and a 0.002% have not been shown to be effective, whereas Povidone-iodine has been shown to be effective.
Okay. Is there a standard medication we can buy over the counter with the correct Povidone-iodine and percentage we can ask for?
I'm assuming this is Kuni from Namibia. Look, you can, I don't know, I'm assuming betadine is available. You can get betadine if you want to over the counter. Or you can eat the other Povidone-iodine rinses. As long as, like I said, the concentration, Kuni, is higher than 0.2%, I would say make it 0.5%. You can buy them, but betadine is available over the counter. It's been for betadine's been around for what, 60 years? It's nothing new.
Okay. Dr. Bradley, here's another question who's asking, can I use only hypochlorous acid to clean everything instead of surface disinfectants?
What do you mean by everything?
I think they're talking about surfaces as well.
Well, I'm thinking, so if you look at surface disinfection, it's used for surface disinfection. It can be used for hand washing. That's what that article by the maxillofacial surgeons have said. They use it in fogging. You can use it as a mouth rinse. They are using it extensively, but I don't want to paint the picture that the hypochlorous acid is a silver bullet for everything. Because remember, when it comes to surface disinfection with all these disinfectant agents, if you've got too much dust and organic material and stuff on the surface, it affects the efficacy of the agent. The only one that seems to have not been affected by this one study that I showed was Povidone-iodine, which was not influenced by other organic material. It still was very effective in killing it. But the problem with the Povidone-iodine for surface disinfection is you could have the staining issues if you keep wiping your surfaces all over with that. So that's why I'd say, you be careful in just thinking you can use it for everything. And it's clear we use it for our surface disinfection, but that's between each patient. So we clean at the start of the day, the dust and everything, and wipe it. And then we have our half an hour break in between each patient, and we wipe down the surfaces. But I have fogging in my practice too. I have a company that comes and does it for me periodically. And again, it's about just having enough checks and balances in your practice that you feel comfortable enough with working. I mean, I wear the full body suit, the face shields, the masks. I do all that with every patient.
Okay, thank you, Doc. Would adding a flavor...
Hi, sorry, I just want to... The lady from Namibia, the mouthwash and gargle is available in Namibia. So
gentlemen.
1%, mouthwash and gargle in Namibia. And the second question, or the second thing, when it comes to staining, the mouthwash and gargle has been formulated and tested in terms of staining. And we've got data to support that with teeth staining, the Povidone-iodine mouthwash and gargle doesn't cause teeth staining. So it is okay to use. Yeah.
Okay, Dr. Bradley, would adding a flavor reduce the efficacy of hydrogen peroxide? Dr. Brad? Dr. Pierre, maybe you can come in there. I think Dr. Bradley's having connection issues.
So what is the question?
Would adding a flavor reduce the efficacy of hydrogen peroxide?
sorry, I cannot comment on, adding flavoring to hydrogen peroxide. Yeah.
Thank you, Dr. Pierre. I don't know if we're going to try to get Dr. Bradley back, but all the questions that are here are related to him and his presentation. We have about 15 minutes until we end our session. So maybe Dr. Pierre, I can give you this opportunity just to give us your last thoughts and your parting shot, and yeah.
Thank you. I think from my side, working with the povidone-iodine molecule, there's been a lot of information that we've been getting, or I have been seeing by global experts in terms of using PVPI, in their practices, from oral surgeons to all dental types of specialities, also ENTs, head and neck surgeons as well. And they have been advocating that, PVPI will assist with reducing the risk of contracting, coronavirus or SARS-CoV-2. There is literature that they have published, and if there's any of that information that you want, please reach out to Sada and I can send that through to you. If you need any information related to povidone-iodine products, please do reach out as well, and I will share that with you.
Thank you very much, Dr. Pierre. No, it's fine, Dr. Breedekam. I think because we don't have much time left, let me give you this opportunity just to give us your parting shots. All the questions, I see there's a lot of questions, all the questions that are still left behind, Dr. Bradley. I'm afraid if you're having connectivity issues, we shouldn't continue any further. All the questions will be sent through to you, and then you can just respond to all those questions, and then we'll send them back to the members. So I think let me give you this opportunity. We do have like 10 minutes left. So let me give you this opportunity to just give us your parting shot.
So firstly, thanks to Sada and Monday Farmer for arranging this. Thanks to the delegates, the people attending for giving up of your time. And it looks like you didn't feel it was a wasted hour and a half. So I'm very happy for that. The main message I want to give you is there is a way for us in this country, in this climate that we're in, to try and protect ourselves and our patients without spending an arm and a leg, because we don't all have the means to be spending a lot of money. And be careful of panic buying. I know guys are spending a lot, and it's fine if you have the money to spend it, but don't put yourself at financial risk because you've had 2 months where you haven't had an income. So try and think creative and find ways that you can protect yourself and your patients that are not as expensive. And if you then have the means to spend the money to buy extra stuff and add extra layers, then albeit. But remember, for you, basically, PPEs, pre-procedural mouth rinses, and a rubber dam. That's the most important thing, the bare necessities. Thank you.
Thank you very much, Dr. Bradley. Colleagues, let me just take this opportunity to apologize for having to cut the session, but it's only 10 minutes left. But then I assure you that you will get your full CEUs for this session, and Dr. Bradley will respond to each and every question that is presented. Unfortunately, technology comes with its own problems, and that's just the way it is. So I think we'll just conclude this evening here. Thank you very much for attending the session, and I'm going to ask Dr. Pierre and Dr. Breedekam just to remain behind while we allow our participants to just exit. Thank you very much.
Thank you.
Thank you.